Hi friends, most of the time polar cataracts are uneventful, but sometimes they take a bad turn. This was the right eye of the patient. He presented with bilateral polar cataracts almost symmetrical and identical to each other. I decided to operate the right eye first after proper counseling about the need for a 3-piece IOL and also explaining the risk of posterior capsular dehiscence that can occur during the surgery. After the capsular excision, I perform a very guarded hydrodelineation procedure. Because the nucleus grade was slightly about 2+, the hydrodelineation was not very clear. I uncap the epinucleus and I'm going to do a direct chop in situ. With a power of 30% and a vacuum of 300 millimeters of mercury, I bury the phaco tip and create the chop. I do not rotate this nucleus in any way because I have not done cortical cleavage hydrodissection, and this will place stress on the zonules. After removing a single fragment of the nucleus, I then bury again and create another fragment, and this piece is also emulsified. I continue in this fashion without applying any rotatory maneuvers to the nucleus, just chopping it up and eating it in situ. Phaco emulsification has been done by a very low phaco settings, what is called the slow motion phaco. The subincisional piece is simply pulled downwards, not rotated, and then eaten up. The epinucleus is not going to rotate, so the aspiration of epinucleus is done with a moderate amount of vacuum, in this case about 250 millimeters of mercury, and I'm using the phaco probe itself because of the thick nature of the epinucleus. The subincisional epinucleus is a little tricky. You can either use a visco expression or you can use what is called the mechanical cleavage, and with the help of a Sinskey hook pressed to the equator, you can give a slight pressure towards the equator of the capsular bag and then pull it inwards. This will usually dislodge the epinucleus, and once it comes within the central area, the epinucleus is carefully removed in the epinucleus mode settings. While performing the viscofluid exchange, the important thing is to maintain the volume of the anterior chamber. Neither allow the chamber to collapse nor give too much of viscoelastic that will hyperinflate the anterior chamber. Cortical aspiration is little tricky. This is a sticky cortex. Always aspirate the cortex from the periphery in an inwards fashion. Do not try to remove the central portion of the cortex first. In this manner, I was able to get out all the cortex. I even managed to clean up the posterior capsule, though this is not highly recommended in a polar cataract. So once all the cortex has been evacuated, the intraocular lens is implanted. This patient went on to do very well. Emboldened by this result, he chose to have the left eye surgery also, and this was performed after a week. The polar cataract and the nucleus grade was almost identical in these two cases, the only difference being that my retroglow instrument had developed a glitch, and therefore I was not having the benefit of a good retro illumination. However, I performed a good capsular excision that was just around 5 millimeters in size. I followed almost the same principles that I did in the previous case. The hydrodelineation is done in the mid-periphery because this nucleus was hard. Small aliquots of fluid is injected in order to try to create a small amount of hydrodelamination wave. Now once I've achieved this, the phaco emulsification was carried out in the same settings, a same grade of nucleus. So uncap the epinucleus, and now I'm going to bury the phaco tip inside the nucleus substance and create the chop. So the first job happened and I got the good chop and separation, and then I created the second chop as well, very close to it. This is an in situ phacoemulsification. No attempt was made to rotate the nuclear fragments. So once I was able to isolate a single fragment, this fragment was then taken out. Only unlike the previous case, this fragment was a little large. It was while I was trying to remove this fragment that I noticed something quite alarming. For a split second, I'm slowing down the video, I realized that the posterior capsule has opened. There is a dehiscence of the posterior capsule. I was so nonplussed at seeing this that I simply pulled out the phaco probe. You should not do this. You must always do a viscofluid exchange. However, in this case, there was no positive pressure and the chamber did not shallow, and I got away without a viscofluid exchange. The next step, of course, is I'm not going to put the phaco probe back into the eye, because the increased fluidics of this may cause rupture of the anterior hyaloid phase also, and vitreous may come into the wound. At this stage, there is no vitreous in the anterior chamber. Using a Sinskey hook, I maneuver the fragments of the nuclear pieces in a favorable location. I try to bring it into the anterior chamber. After giving a soft cushion of visco between the nucleus fragment and the posterior capsule, I now extend the clear corneal incision with the help of my keratome. Now, while extending the clear corneal incision, try to maintain the tunnel effect that you have created with the clear corneal incision. This is done by making gentle sweeping motion towards the side and coming out towards the scleral end of the opening. The extension of this clear corneal incision is done to about 5 millimeters. Of course, I could have sutured up this incision and taken a scleral tunnel incision as well, but I just chose to extend the incision to about 5 mm because the nucleus doesn't seem to be very hard. The first thing that I try to do is create a fish hook, which I learned from my seniors. However, unless you have a good experience with the fish hook, I realize that's not so simple to remove the pieces. So one is, it's difficult to pierce these pieces to bring it out, and secondly, cheese wiring occurred. Therefore, I switched on to the vectors. Then use a sandwich technique and try to remove it. All the time you have to give a buffer of methyl cellulose, maneuver the pieces to a favorable location. Use a sandwich technique because the hypertony, just using the vectors and trying to pull it out horizontally, may actually cause the piece to tumble. In order to discourage the tumbling effect, you have to use the Sinskey hook. And the epinucleus will come out of this 5 mm opening. It's just that this nucleus fragment 3-dimensionally is too large to come out. Therefore, you need the vectors and the Sinskey hook in order to grasp it. Although it looks quite dramatic, you may feel that the endothelium could be damaged. I'll show you the first day post-op pictures. The cornea was very clear. Once you've downsized the nucleus to smaller fragments, you can use a visco expression technique to get this piece out of the anterior chamber. So now what's left behind is the epinucleus and cortex. But I'm sure that the hyaloid phase has been broken now, so I use a 20 gauge vitreous cutter. I use the cut IA mode in order to cut out the vitreous from within the central part. Simultaneously, you can use the aspiration mode and also the irrigation fluid. I'm just depressing the lip with a little amount of irrigation and the piece comes out. Just see how you can use the irrigation itself to get the piece out. Once you've cleared the anterior vitreous, with the help of a foot pedal itself, I can convert the mode from a cut IA to a IA cut mode. And when I switch to IA cut mode, I can use the vitrector and the irrigation simply like a bimanual IA system. You don't have to exchange the vitrector to a bimanual. Only thing is, when you're using the vitrector in the bimanual mode, make sure you increase the vacuum to at least 250 to 300 millimeters, otherwise it will not aspirate the cortex. And then when you're going to the cut IA mode, reduce the vacuum to 150 to 200 millimeters of mercury. That's the only thing that you have to do, and if you do that, you can simply use the vitreous cutter itself as a bimanual instrument. Because the rhexis is intact, I am now attempting to put a 3-piece IOL in the sulcus. This is the single most important thing that you have to do. Prevent a secondary accident. Do not damage the anterior capsular rim. Do not compromise the capsular rhexis. The presence of an intact capsular rhexis is a watershed zone that is not only going to limit the amount of vitreous coming out of the eye, it will also enable you to place a sulcus 3-piece IOL beautifully in place. I'm able to get the 3-piece IOL nicely into the sulcus. I tap it to look for stability of the lens, and then I constrict the pupil with pilocarpine. Now once the pupil is nicely constricted with pilocarpine, this is when I'm going to use my triamcinolone acetonide to see if there are any vitreous fibrils that are popping out from the pupillary edge and coming into the anterior chamber, getting stuck like a wick to the incision. And I find that in this particular case, there is no vitreous wick at all. So I put an air bubble in the anterior chamber. The air bubble nicely sits into the anterior chamber. And then this wound has to be sutured. I'm using a 10-0 suture, and I'm going to take a shoelace type of suturing to close up this clear corneal incision. The patient did very well in the post-operative period. I'm going to show you the first post-op pictures. And at the end of 1 week, the visual acuity was 6/6 in this eye. This is the first day post-op view. The air bubble is still there, the pupil is round, there was almost no anterior chamber reaction. At the end of 1 week, we dilated and had the retina surgeon to have a look at the case. There were no large fragments left behind in the vitreous. There were just 1 or 2 very small bits of cortex that could be seen. And according to retina surgeon, this cortex did not need any intervention to get absorbed on its own. Thank you for your attention.